In regard to the novel treatment of the protease inhibitors that we just heard about in regard to hepatitis C, know that they're making a big difference, and we know that we now can claim that we have a therapy that can cure HCC. But however, the willingness to kind of have everybody get access to that therapy is not 100% yet. And in other words, there's still a feeding pool, unfortunately, within that had the HCC related to hepatitis C that we're seeing as well. Thirdly, it appears to be that the consumption of alcohol, especially heavy liquor, among younger population is unfortunately still on the rise, and this we are not seeing yet in regard to any change in regard to the number of HCC patients related to alcohol, even though it's not less, but it's not higher. And lastly, of course, the non-alcoholic fatty liver disease on the NASH. This is by all means, as we heard from many of us, is definitely on the rise because sadly we have morbid obesity and diabetes, which is relieving quite a bit of the activity in our population at this point in time. With this said, we kind of like gather a lot of thoughts about the importance of the multidisciplinary team in regard to HCC. We already got a few glimpses about the involvement of many people. At least here we have several oncologists, but we have hepatology as well represented. But of course, there's other disciplines which are really critical in that regard. And I'll start off the bat, and you know, I will ask my friends. Ruth, do you go to a disease management team or a conference on regard to discuss your patients with HCC on regular basis, or what's the story there?
Yes, so we meet weekly. We do have a multidisciplinary team.
You do.
And it's actually led by the transplant team. And so then the team is composed of radiology, a very good radiology who knows how to read liver imaging, and interventional radiologists who provide liver-target therapy for earlier stage HCC, and medical oncology and hepatology and transplant team, and sometimes radiation oncology who will be there to provide support for the radioembolization. Currently, we do not have a pathologist on board because I guess not all the cases have been biopsied, but I think I do foresee in the future we might get a pathologist involved in our team.
Fair enough, but it's very important. And Manish, do you do the same? Do you have a multidisciplinary team that meet on regular basis?
Yes.
How regular?
Yes, we do have a liver tumor clinic, in fact, and so we see the patients in a multidisciplinary fashion, and we also meet on a regular basis weekly, where I do attend that meeting, make an effort because I'm the medical oncology representative there, and we have the other same fields as Ruth was mentioning, present, and it really is a critical meeting, especially I think when the major divide is whether a patient is someone who's a resection or transplant candidate versus not, right? And that's kind of the most important decision that typically gets made at that meeting. And if they're not a resection or transplant candidate, I know they're headed my way for systemic therapy options, and that's critical to kind of make that decision as a group.
I totally agree with you. If anything, I will say it on a light note, but one time I was visiting some colleagues at another institution, and I asked, out of curiosity, when is your multidisciplinary team for HCC? They said it's this afternoon. I said, oh, well, great, we'll go there. They said, oh, we're busy in clinic. So I insisted that I went on my own. And I'm not kidding. Patients were referred even to hospice care because there was no medical oncologist to even offer therapy. Nowadays we have multiple more therapies, and of course probably there will be more attention to that. But in those days when really therapy was limited or probably barely existent, the thoughts was rather than having clinical trial, what have we, is to go there. Please, is a very important urging that I have for all our colleagues who are medical oncologists. You got to be at that meeting. Don't let it be run only by the transplant surgeons, by the surgeons, by the interventional radiologist and the hepatologist. You got to be there because you have a voice that needs to be heard, and you have also a lot of help and opinions that you need to be given in regard to the care for the patient. So that's definitely, this goes without any go.